All right, welcome everyone. I'm Dr. Kaplan of Om Integrative Wellness, and this is kind of our monthly discussion on regenerative medicine applications for different musculoskeletal problems. I just want to give you a brief introduction of who I am, in case this is the first time you're hearing this talk. Dr. Kaplan, I founded Osteopathic Integrative Wellness. The original name was Osteopathic Wellness Medicine. Now we go by Om Integrative Wellness. In 2014, I am a traditionally trained sports medicine doctor, trained in interventional spine and sports procedures. And basically, around early 2000s, I decided that I was having kind of a frustrating time treating folks with just steroids and physical therapy, and felt that there was more out there, and then slowly started to move on to regenerative procedures, starting with PRP, and then eventually kind of advanced to other procedures. But you know, it was an environment where, in a traditional medical setting, where I felt very limited, and I decided to open a full wellness and a regenerative center that gave me a lot more flexibility of how to treat people, with the main goal of treating the entire individual. When somebody comes in for a problem with their back or neck, as the topic of the day is today, there's usually more going on than just that one area. So we typically do look at overall inflammation, just the overall wellness of the individual, and we try to tune the person up to really make whatever we're going to do for the person as effective as possible. And now, over the last year or two, we've started intravenous nutrition, which really moved the needle in helping people really get rid of inflammation and feel better faster. And as you'll see, when we do these regenerative procedures, they rely pretty heavily on your body's ability to repair. So when we can give somebody an intravenous nutritional support to bolster their natural metabolism, it actually makes their ability to repair much faster. So it's, things are moving very quickly, and this is a very exciting field to be in, because again, every year I seem to have better and better tools to be able to help people recover and heal naturally. And that's really what this is all about: avoiding surgery and repairing naturally, and, really without a lot of downtime. So without further ado, I'm going to go ahead and start the presentation. Today's presentation is on regenerative medicine applications to specifically neck and lower back. So let me go ahead and start the PowerPoint here. All right. So what I wanted to start with is just basically explaining what regenerative medicine is. Regenerative medicine is a process where you are creating living functional tissue, and it's meant to repair a tissue that's been injured. It could be injured due to or lost due to age, disease, damage, or congenital defects. Now, the field is not limited to musculoskeletal system like the spine or the joints. There's research going on in regenerative medicine on organ regeneration, traumatic spinal cord injury regeneration. You guys all remember Christopher Reeves and his foundation. So it's a very expansive field, but in my area, we're focusing primarily on the spine and the joints and trying to help them repair in a natural fashion. So let's go through a little bit of the history of Prolotherapy. And what I wanted to specifically focus on is the fact that Prolotherapy is kind of the granddaddy of regenerative therapy. Prolotherapy is a traditional approach where there is an injection of a dextrose solution, in addition to maybe another mild irritant, into an area of injury. And the use of prolotherapy has been essentially applied since the early 1800s It was initially used by general surgeons to repair small hernias. And for our purposes, when it really started to become the modern version was in the 1930s with this physician, Earl Gadney, who hurt his own thumb in essentially a house improvement project, tore a ligament. He had a really loose thumb joint. It was really having a lot of disability and pain from it. Was unable to find anyone to fix it, and stumbled onto this prolotherapy approach. He injected his own thumb over a number of times with this dextrose solution and essentially healed this ligament and was able to regain function. So because this joint was kind of floppy and loose and was a source of so much discomfort and disability for him, he published an article on prolotherapy and labeled it the treatment of the hypermobile joint. This is the first time that term was coined, essentially in medical literature. And it is now really a foundational concept for understanding chronic dysfunction and chronic pain in the spine and joints, this hypermobility that is very difficult to treat in any other way. So in 1950s, Dr. Hackett, who was a general surgeon, observed that after surgery, injecting prolotherapy sped up repair of his incisions, and then he eventually started to just use it for repairing areas of injury without surgical intervention, finding great results. He coined the term Prolotherapy, which is short for proliferative, and proliferative is basically just a word for generation of new tissue and growth of new tissue. In 1960s, he paired up with Dr. Hamill, who was an internal medicine doctor, and they together founded this Prolotherapy Association, who is alive and well today. They have an institute in Madison, Wisconsin, and I'm a graduate of that school. And the approach that is used for the injection of the ligaments and the damaged tissues is called a Hackett and Hamill approach. And I use that in my clinic extensively for these regenerative treatments. So basically, again, what is prolotherapy? Well, it's the rehabilitation of an incompetent structure and promotion of generation of new cellular tissue. It's done so by this purposeful mild irritation of the tissue that's been injured, which then stimulates your body's natural repair response. So just to give you a sense of some of the points where prolotherapy can be injected, all the black dots in the skeleton all the way up to the base of the skull and down to the tailbone area are all areas that could be injected. So just take a look and see how many different points are typically in our human body can be broken down where the ligament has been injured in some way and where the prolotherapy could be administered. It's quite striking. So moving on, so this point where you saw these black dots on the skeleton are called the anthesis. The anthesis is basically an anchor point where the ligament is anchored to the spine. And those are the areas of structural stability. Wherever there's a tethering or an attachment of a ligament or a tendon on the bone, that's where that ligament and tendon is creating stability and limiting excessive motion. And what you see on the right side is this graph where showing basically a fine balance between a little bit of tension on those areas of the anchor points, which actually is very good for strengthening of cartilage and ligament, showing that when that tension is exceeded, when it actually exceeds what the tolerance of the tissue is, it can lead to breakdown. So the most extreme example of that, of course, is like a tear with trauma. But even with repetitive overuse, when it stops being just an occasional kind of gentle therapeutic stress, just like you would get with just walking, for instance, or just some exercise, controlled exercise. When it's exceeded, the tissue no longer is strengthened, but it breaks down, and at that point, very commonly becomes a source of chronic pain and instability, and as I mentioned before, hypermobility. So, because this typically happens very, very slowly over a period of time, this breakdown, the body actually doesn't recognize that breakdown of the attachment points as injury, and there's no attempt to repair. And this is where these reparative regenerative treatments come in. They actually kind of trigger and kind of trick the body into thinking that there's a new injury in the area. And then all of the growth factors and the stem cells and all of the natural healing elements that the body typically deploys to repair are sent to that area. So just a great, great natural process. So the next slide I want to kind of talk about is this concept of what happens when these anchor points are functioning properly. Well, they essentially create something called tensegrity. Tensegrity is two terms meshed together, tension, integrity, and it's an architectural term to basically illustrate how tension, when it's evenly applied to a structure, creates stability and balance. And if you look at the picture on the bottom, you will see this large sculpture of these seemingly floating beams. If you look at the background, the trees are quite small, so it gives you an idea of the scale of the sculpture. And these beams are kind of floating in the air, and that's, of course, done and accomplished by these cables that you could see there attached to these beams, creating this even tension suspending these beams. So tensegrity. If you look at the top picture, this is a picture of the pelvis, the back portion, the purple structures are ligaments, and you can see how they run evenly in both directions, creating that very similar symmetrical tension, which creates stability, in this case, around the pelvis. Think about one of those ligaments tearing and loosening and all of a sudden losing that symmetry, and you can imagine how the joints will start to shift and shear, which will eventually lead to breakdown of cartilage inside, pain, and disability, again, leading to this hypermobility or excessive mobility that we talked about. So that's just kind of the underpinnings and the basic information I wanted to share about how I look at a chronically painful area. Okay, typically it's an area that has breakdown of this tensegrity and essentially a chronic injury of these antheses or these attachment points of ligaments and muscles and tendons. So now I'm going to just go into other types of regenerative treatments that we see. So prolotherapy I discussed. I still use prolotherapy. It's a concentrated dextrose solution. It's typically better served for milder sprains and maybe just very, very early onset arthritis. But then in most cases, by the time people come and see me, they're already kind of in a more advanced phase of wear and tear, and we're usually going to resort to something stronger, most commonly starting with platelet-rich plasma. So if you look at the following picture, this is the container that we use to essentially inject blood into that we get from the vein at the time of the visit. It's spun down, and platelet-rich plasma is this red and pink layer on the bottom of this yellow layer, which is just clear plasma. And that contains 10 times the concentration of growth factors that you would see just circulating in your blood at any random point. So this super, super concentrated solution is then drawn out with a syringe and then is injected into the areas of injury. So just some of the science behind PRP. There have been many studies that have shown benefits. There's some interesting ones that I wanted to kind of share with you guys here. One is that PRP actually has some potential to reduce inflammation, not just in the joint where it's injected, but actually also systemically. So there's this one factor that the body expresses when it's inflamed called interleukin-17, and they drew these levels before and after a PRP injection into the knee and found that these levels actually reduced, which is pretty remarkable to think about, that an injection into the knee can reduce overall inflammation. The other study, which I really like a lot, is a study where they follow people with MRIs for up to 12 months, and after a single injection of PRP into the joint. Now, this is done with the knowledge that under normal circumstances, once the knee is arthritic, it will tend to lose 1 millimeter of cartilage per year. So if you get an MRI done every year and measure the cartilage, you will see a thinning of the cartilage by about 1 millimeter. Well, when they did a follow-up MRIs on this population, they found that in 73 of the subjects, there was no progression of cartilage loss, which is really pretty amazing, especially considering there was only one injection, and we typically do more than that to really promote full repair. So quite amazing stuff. So what are the uses of PRP? Well, as I mentioned, it's used for arthritic joints. We use it for arthritis of the neck, lower back, and mid-back all the time. Any pelvic joint issues. It's amazing for tendon tears. It's a go-to for rotator cuff tears. It's really, really good for meniscal tears. I have a success rate of over 90% with healing peripheral meniscus tears with just 2 injections done, let's say 3 or 4 weeks apart. And, I really want to emphasize that most meniscal injuries do not need to be operated on unless you have a very large tear, like a bucket handle tear that flips over and gets stuck in the knee and locks the knee from moving. Most meniscus tears do not need to be operated on, and there's definitely a problem in this country of really performing unnecessary surgeries for these tears where they could be healed naturally with platelet-rich plasma. There are some other uses that are they're growing and now becoming quite common. You could inject PRP into the scalp and promote hair growth, and it's actually can be even aerosolized to help repair lung lining, and it's now even been used experimentally for trying to see if we can speed up the traumatic brain injury and promote repair. So let's move on to stem cells. So what you see on the picture here is a container of a fat-derived stem cell product that has been spun down in a centrifuge, and all the oils have been essentially separated. On the top and the bottom, like the little very top, there's a very clear yellow layer, which is kind of oil, and on the bottom there's another red layer, which is a little bit of blood and oil. In the very middle, there's this nice orange kind of a fatty layer, and that is the fat that contains all the stem cells. Again, it's been concentrated extensively, and that could be injected into a torn or broken down tissue. Now, you can also get stem cells from the bone marrow, from the back of the hip. A very simple procedure which takes about 5 minutes. Those stem cells can be extracted, spun down as well, and injected. The difference between choosing whether we get the stem cells from the fat or from the bone marrow has to do with the age of the person to a certain extent, and also just the extent of the injury itself. The fat stem cells are a little bit more pricey, they're a little bit more laborious to get, but if someone has a fairly advanced degenerative process, we will probably choose that because they're stronger. And we also know that fat seems to be a little bit more active. The stem cells in the fat seem to be a little bit more active in the older years. So I generally will pick that instead of bone marrow with folks after 70. So just another kind of fine point of figuring out what to use and when. So what is a stem cell? Stem cells are basically cells that have an ability to divide and develop into many different cell types in the body. Now, this slide is a little outdated because we now know that it's at least 80% of what the stem cell does is actually conduct a healing process by turning on the actual genes in the injured cells themselves and essentially turning on the repair in those cells. So it's almost kind of like a foreman that comes to the site and starts directing the workers to construct the building on that construction site. So it does that by secreting these exosomes, which are little pockets that have genetic material in them. And that genetic material then is attracted to where there's inflammation, where there's injury. They actually bind with the injured cells and then kind of conduct and promote this turning on of the repair by the cells. So very, very cool. Now, stem cells, when we're in the uterus and we're just born, are considered to be embryonic stem cells, and these stem cells are able to become everything. We call them pluripotent stem cells. Very, very quickly, though, the stem cells change to more of an adult-type stem cell, which is called a mesenchymal stem cell. And those stem cells are called multipotent, which means that they can be many things, but they can't be everything. And fortunately for us, some of the things they could still become are going to be more like cartilage, ligament, and tendon, so it's still very useful in that arena to use them. Now, the next picture just basically shows you that there is a difference in how these stem cells are made and isolated. And it's honestly the same with the PRP. You know, cheaper kits that some offices get just to save money do not isolate and concentrate the fat. And you see how it's, there's this picture with this one syringe that's kind of similar to what I showed, and the other one is everything's kind of mixed together. Well, if you inject it into the body, first of all, you're injecting a lot of inflammatory cells. It's a lot more painful. And honestly, it's not really as concentrated, so it really doesn't work as well. So there is definitely a point to be made about the quality of the stem cells that are being extracted, how they're being extracted and processed. All of that adds up to a better clinical result. So let's talk about briefly safety. Very, very, very safe. There was a study done in specifically on mesenchymal stem cell injections, 2,800 patient study, multiple studies showing no adverse outcomes. So can't beat that. And then as far as the studies go, again, they're going to be a little bit more limited because PRP is not, stem cells are not like PRP, and the research on stem cells is very limited to animal studies and bench research, meaning that it's in the lab. So what you're relying on are either animal studies or these outcome studies where basically you've already done injections on people and now you're collecting data to see how they've done. And they've collected, in this one study, 2,300 patients from they kind of pulled 61 studies. All of these patients had osteoarthritis, and they concluded that the therapy is beneficial, although the design can be better, of course, because you're pulling so many studies together. What I like better is the study below that, showing how well stem cells worked in these greyhound dogs. They took 130 greyhounds that were retired from the track, all with arthritic joints. They did hip-drawn mesenchymal stem cells from those dogs, injected them into their arthritic joints, and found significant improvement, 92% of significant improvement followed for 6 months. And this is fairly recent, published in 2018. So the from the standpoint of looking at how these stem cells work, the other aspect is that we know that stem cells also have an ability to be very potently anti-inflammatory. Again, kind of similar to PRP, but even stronger. So we also know that, let's say, an example of an osteoarthritic condition, it's not simply a wear and tear condition like we used to think. It actually has very, very potent inflammatory chemicals that are floating around. And one of the additional ways that the stem cells work is by blocking these inflammatory chemicals, which have been shown to be really destructive to the joint. So when you block those inflammatory chemicals, you are preserving the joint. So there is really another additional benefit. You're working on repairing the injured cells, but you're also blocking inflammation that could potentially cause further damage. So some of the applications, the anti-inflammatory applications, there was a study done showing that when you injected stem cells into a tibia or a knee joint of a mouse that actually has been in a controlled environment, was actually had an induced fracture. So they actually fractured this tibia, the tibial part of the knee joint, which normally in most cases would lead to arthritis. They found that when they injected stem cells into that area, it prevented degenerative changes from occurring after this fracture, which is pretty amazing, actually. They also found that after a meniscal resection, so this is basically what a person would get with a meniscal tear, the progression to osteoarthritis was also prevented when stem cells were injected. And this was in the rat model. It's quite amazing. Typically, when you have a meniscal surgery currently, it's almost a given that at some point there's going to be an arthritic process developing. So when you can inject stem cells and prevent them from happening, I would say that's a pretty significant advancement in just the state of medicine in general. So how are these stem cells used then? Well, they could be used similar to PRP. Think about them being used for more degenerated conditions, for conditions that require repair, okay? And more repair than a PRP would be used for. And certainly for joints where people are ready for like a replacement, or if they go to a surgeon, they're told that they need a joint replacement. So the other, you can use stem cells that are purified for infusions for autoimmune diseases. We're now leaning more towards these exosomes for that purpose. Neurodegenerative diseases, infusions for those have had some promise. And again, they can be aerosolized for immune conditions and promotion of central nervous system damage, for instance, like in traumatic brain injuries and strokes. So just very, very exciting potential developments there. What's the future of stem cells? Well, the future is constantly changing. Some of the things on the horizon are some machines that are available that can actually count and sort stem cells to just pick out the healthy ones. We make stem cells in these crops or populations, and within this population, you're always going to have some wimpy stem cells and some really vibrant ones. Wouldn't it be nice if you can just pick out the healthy ones to inject? Well, this machine can do that. Of course, it's very expensive presently and not quite ready for prime time. We also have the ability in the lab to turn a stem cell from an adult to an embryonic stem cell, which means that it could be, much better, adapted to dividing and becoming the injured tissue, that we're trying to treat. The problem is, when the stem cell becomes embryonic, it divides very rapidly, and there's concern about cancer. I don't think there's really a way right now to turn that division off once you've injected. So there's some concern about potentially creating some cancerous tissues. Again, not quite ready for prime time, but certainly something to be looking for in the future. So the process in the clinic, I talked about that I use a Hackett and Hamel approach. This approach, again, is specifically focused on repairing and reestablishing this tension integrity of whatever structure that we are working on. So we're injecting multiple points around the area of injury. It is never a one-and-done approach, which is, by the way, very commonly done in a lot of orthopedic offices that do regenerative treatments. Of course, they mostly use these treatments for joints, not necessarily for spine. That's more unique to something that I do. So let's talk about some cases. The first one is going to be for the neck specifically. And I want to just talk about this one particular case of a whiplash injury of a 41-year-old female volleyball player. actually a coach, sorry. It was a loose ball that she got hit on the side of the head. It was all the way in 2001, and she saw me in 2018. And she complained of constant chronic headaches, upper neck pain. She also had a lot of dizziness, blurriness of vision, cloudiness of mentality, and it was constant, and it was quite limiting and disabling. On the exam, it showed that there was a lot of motion in the upper area, kind of at the junction between the head and the neck. And some of that motion was felt more on the right side, with a loss of this normal stop of motion that should occur by the tension of the muscle and ligament. Now, interestingly enough, the MRI didn't show very much. And again, this is just to illustrate that we can't really use MRIs for these chronic injuries. They really are only good at showing acute nerve damage or maybe like a large disc herniation. Way too much emphasis is being placed on MRIs as kind of like the be-all answer for figuring out what's wrong with the spine. So the ultrasound actually then was done as well, and that just confirmed that there was a disruption of the ligaments. So we started in the beginning with Prolotherapy, knowing kind of now what I know, and had I known that then, I probably would have started right away with PRP or even stem cell treatments. Again, we did a couple of rounds of just dexterous Prolotherapy. It really did not do much. She had about 30% improvement with headaches, a little bit less pain in the neck, but still had a lot of instability and a lot of vertigo and dizziness. We started with PRP injections following that. And actually, a single PRP injection in that area produced 75% pain relief and resolved dizziness. And that's pretty amazing. Think about 2018, right? So her initial injury was 2001. There is no other treatment in a conventional medical toolkit that can accomplish something like that. It's really quite striking. Okay. On the exam, there was reduction of neck instability and reduction of pain with deep palpation of that area. Interestingly enough, she was supposed to get another treatment, but did not come back until after the following summer, and basically came back because she was hit by another flat loose ball and kind of re-injured her neck. So just ironic, again, coaching. So we went ahead and treated it again with PRP and really brought things back. She did not re-injure it as badly as the first time, fortunately. And she then really had significant improvement in pain and almost complete resolution of instability. So just to go over the anatomy, here you have cervical ligaments. You have this big white ligament that runs down the middle of the neck. That one gets very commonly disrupted with traumatic injuries or even with progressive kind of wear and tear. The black arrow is also pointing to the ligaments that are on the sides of the neck where the joints are. So those ligaments are stabilizing the joints of the neck. All of those are injected. So you could see that it's not a one-time injection or a single injection. We're really focusing on all these different stabilizing structures. And then the other thing we'll work on are the muscles. You could see that in case of the volleyball coach, there is like this triangle of red, these little red structures, which are the muscles right at the base of the skull, connecting the skull to the neck. That is called an occipital triangle, and that's where a lot of her injury was. The white is the point of insertion. That's the anthesis. So you see each muscle has this white tip on both ends. That's the anchor point. That's where the breakdown happens. When we inject at the junction where that white area is in the bone, it reconnects that attachment and strengthens that insertion point, ultimately then leading to better stability. So let's talk about lower back. So this is a case of a 74-year-old gentleman who came to see me suffering from back pain from a car accident in 2008. Again, notice that these are chronic problems. People are seeing me 10 plus years after. The pain has been recently getting worse. It's been sharp and shooting into the right lower back and buttock. It was worse with walking and changing positions. The patient seemed kind of exasperated at the time of the visit and basically just said, I just want the shooting pain to stop. Now, when we did a physical exam, what it showed was that there was a disruption of these deep ligaments that are on the side of the spine. I'll show you the picture in a minute. And it's really where all that pain was coming from. So an MRI would not have really shown that. Certainly the x-rays would not have shown that. But it's a very, very, very common point of injury. And it's also a very, very important structural kind of tensegrity ligament. And it's called iliolumbar ligament. She also had some pain over the sacroiliac joint and the ligaments as well. So in this particular case, we went ahead and did Prolotherapy and PRP. We actually did 2 PRP treatments about 4 weeks apart. We did the whole lower back area, but we focused primarily on the right lower iliolumbar ligaments and the sacroiliac joint. And he had an amazing result. He had 90% improvement in motion, complete resolution of the sharp shooting pain in the lower back and hips, and then basically was able to go back to walking and playing golf without any limitations. So just a ligament picture. You will see on the left-hand side, there's a picture of the spine. The gray structures are the ligaments. These ligaments are the struts and the supports. Remember the tensegrity picture I showed you? You could see how they're very symmetrically aligned, pulling in opposite directions, stabilizing the spinal column. In the thickest one, you'll see that actually the title there, iliolumbar ligament, is connecting the lumbar spine to the pelvic bone. And that one is the one that was torn in that gentleman's case, and it's very commonly the source of low back pain for many, many people. You'll see the sacroiliac ligaments at the bottom, right below that, stabilizing the sacroiliac joint. All of those ligaments are injected with these treatments to promote repair. Now, it's not just the ligaments that get injured. The muscle attachments also get injured. Like the one in red is a quadratus lumborum. It's a big stabilizing muscle for the spine. Notice that it's also attaching to bone of the hip and the spine. And we also inject those attachments to promote repair and help stabilize that muscle, which then strengthens the back and helps relieve pain. So in conclusion, Prolotherapy, we talked about, granddaddy of regenerative medicine. It basically creates a mild inflammation and mild irritation to these enthesial attachments, basically the attachment points of the ligaments and tendons. The injection usually is comprised of just dextrose or concentrated sugar. It's good for mild sprain strains and kind of early arthritis. For anything else, we tend to go to PRP or stem cells. Remember, PRP is the blood PRP stands for Platelet-Rich Plasma. It's blood derived from essentially your vein that's drawn at the time of the visit. PRP is very good for promoting cartilage repair. It's amazing for meniscal injuries, rotator cuff tears. It's been shown in studies to reverse death of bone through promotion of blood circulation and preventing arthritis after traumatic injuries. Stem cells are going to be a much stronger version of that. They're either going to be drawn from the fat or from the hip bone. They're very good at promoting repair and stabilization of the cartilage. They reduce and in many cases can slow down and avoid progression of osteoarthritis after injury. And it's also been shown to be very effective in promoting an anti-inflammatory state of the joint. So it's blocking inflammation. And remember, I mentioned that inflammation in and of itself can be kind of damaging to the area. So because this has been a focus on the spine, specifically neck and lower back, I just want to mention that there are very, very few things that could be as effective as these treatments. As a matter of fact, I would probably go as far as say that I don't know anything else that could be that effective. I really don't. I mean, the steroids don't help, nerve blocks. The traditional medicine fails chronic back and neck injuries. It really does. I mean, we basically pump people full of steroids. We fry their nerve endings with these radiofrequency ablations. We're masking pain. We're injecting constantly. We are not helping people at all. And then when they fail, they go to surgery. It's a horrible system. It's a system that needs to be revamped, really thrown out, and unfortunately, what I would tell you is that the reason why it's like this is because insurance companies are not willing to pay for anything else. They are willing to pay for these procedures, and this is why the doctors are allowed to continue doing them, because they're getting reimbursed, So it's a broken system. If you're looking for an alternative that actually works, that's holistic, this is your alternative. I've been doing this since 2014. I've had amazing results and amazing, just amazing success stories of folks who have been suffering from these problems for a long time before they came to see me. So I appreciate your attention. Please don't hesitate to contact me for any questions. You can reach out at my general informational email, info@omeintegrativelwellness.com. Please go on my website, Home Integrative Wellness, and take a look at the regenerative medicine option and see what kind of things I have to offer for problems like this. And I would love to have you come and visit and check out the office. Thank you again for your attention. Actually, there's a question here. Hang on for a second. If I can kind of pull that up here real quick. Okay, let me see here if I can see if I could see the questions. I'm sorry, I'm trying to click on the question box and it's not popping up. Let me see if I could do it here. Okay, let's see. Okay. So do you have any success with stem cell injections to a knee with a partial ACL tear? I had a PRP injection for my knee in 2017, which helped the meniscus, but recently re-sprained the knee. Absolutely. So as long as it's not a full tear, the ACL can be repaired with either PRP or stem cells. As long as the sleeve of the ACL tendon is intact and it's not a complete detached ACL, we can inject along the ACL and strengthen that tendon. I actually do that all the time. A lot of times there is a concomitant meniscal injury, so we typically will treat the ACL and we'll treat the meniscus as well. And then remember this whole tensegrity concept where the knee frequently is loose and there are other points of attachment need to be treated. So essentially we kind of do a 360, injecting all around the knee to create stability as well as injecting along the ACL. So the short answer to your question is absolutely, this could be very, very beneficial. So if there are no other questions, I appreciate you guys watching this Facebook's live. Share it with your friends, and we'll see you in 4 weeks for my next presentation. Actually, I'm sorry, there is one more. What about osteoarthritis of the knee? When is it far gone for you to help? Okay, this is an interesting question. So osteoarthritis of the knee is probably one of the most common conditions that we treat. It's very rare that the knee is too far gone for these treatments. Now, it's possible. What we do is we use a combination of x-rays and an ultrasound, and we're looking for joint space preservation. We're looking for any kind of deformity or contracture. So if the joint is locked in like a flexed position and stuck there, it's probably too late. But if the joint has full motion, and especially if the joint actually has some instability, because usually the pain very commonly comes from the instability, not so much loss of cartilage, which is, again, what many orthopedic surgeons don't really tell you and don't really understand. So if we can restabilize the joint, even if there's a lot of cartilage loss, the joint will do better. And a lot of times people will have very little pain and they can regain normal motion. And I see this all the time. If the joint is very, very degenerated, we'll typically go with stem cells. And if it's just moderate, we'll go with PRP. But again, the success rates are fairly high. The hip is a little bit more complex. It seems like there's a point of no return that I see with hips. And for some reason, people wait too long to come and get help. We tend to have a very high pain threshold when it comes to hip problems. So when a hip gets to a point where it's severely degenerated, I find that it's hard to turn that around. But in the knee, a completely different story. Whether it's more vascular, not sure why, but it responds beautifully to these treatments. So the prognosis is usually pretty good in avoiding surgery, even if it's potentially bone on bone, right? So, and a bone on bone is, again, if it's everywhere in the entire joint, it's one thing, but if it's bone on bone in like a certain area, we could still stabilize around that and help the joint. So yeah, I mean, I see that all the time. As a matter of fact, it's very interesting. I'll have two knees, obviously a person with two knees, both looking identical. They will have, both will have a bone-on-bone situation, but one would be unstable and the other one won't. And even though both are bone-on-bone, guess which one has the pain and which one isn't? The one that has ligament laxity, the one that actually has this hypermobility, that's the one that's painful. So that, again, what that's showing us is that it's not always the bone-on-bone that's causing pain. It's this laxity of the joint that's constantly causing it to rub and move in different ways that's causing pain. We stabilize that, and then we reduce the pain. So I hope that helps. And I think looking like there's potentially here typing. Let's see. Okay. So thanks for all the questions. And again, please don't hesitate to reach out for any more questions through our website or just call our clinic directly. You guys have a great evening. All right. Take care.